So very good evening to all of you, and thank you very much for calling me for this talk. Disclaimer that I'm being a surgeon giving this talk on the medical oncology, so I'm filling in the shoes for my medical oncologist who for some reasons is delayed and will be here in some time, but I'll be filling up that. So this is a phase 2 trial data of Pembrolizumab and Cabozantinib in patients with recurrent and metastatic head and neck squamous cell carcinomas. So as we know, these patients have very poor prognosis and suffer from significant morbidity and deterioration of quality of life. And we know that PD-1 inhibitor now, especially with the PD-L1 expression, has shown that there is an OS benefit with respect to these subgroup of patients, but generally it remains a very fatal disease with meager response to whatever the chemotherapy resources and the therapies we have. So there is combination of immunocheckpoint inhibitors with TRK inhibitors also, including the VEGF inhibitors, which has emerged as a strategy of interest. And based on that, as we know that cabozantinib indications are generally in advanced renal cell carcinomas, and patients in advanced renal cell carcinomas with nivolumab combination, it can sometimes use as first-line treatment, and in hepatocellular carcinomas. So I'll not go into the details on the mechanism of the action, but yes, this trial, which was abstract, was presented in ASCO 22 based on this. Some of the data on the pembrolizumab they have taken from the keynote 48, where it's been shown. If you see in this graph, single agent pembrolizumab, if you go on the right hand side completely, the CPS score where it is more than 20, then the median overall survival and your 12-month overall survival is significantly increased. Otherwise, it is same as cetuximab in the chemotherapy. So this study was designed with inclusion criteria of inoperable, refractory or metastatic, recurrent metastatic head and neck carcinomas, and measurable disease on RECIST version 1.1 criteria. And the patient should have minimum or equal to only one radiation therapy prior, which allowed. Life expectancy, where you deem that it may be more than 3 months, those patients were only taken on the trial. ECOG status with 0 and 1. And those patients who had HPV negative carcinoma unknown primary, they were excluded along with cavitating lesions or the recent bleeding history. So these patients, it was a single arm trial, open label multicentral, and put onto pembrolizumab, that was 200 milligram IV3 weekly, plus cabozantinib was given 40 milligram per orally. And tumor was then assessed by the RECIST criteria every 9 weeks based on the CT and MRI findings. So the objective was to define the safety and the tolerability of the pembrolizumab plus cabozantinib combination in this patient population, and to see what the objective response criteria comes. So the patient age group, it was small data, 36 patients only. Age was in 60, median age 62, with majority male patients, good ECOG performance status. Majority of primary was again seen in oropharynx rather than oral cavity, and some patients were in nasopharynx. 16% was in nasopharynx. HPV positivity was equally distributed, almost like 50% of the patients were HPV positive, and prior radiation and chemotherapy were received in almost 100% patients. If we see the CPS score PD-L1, again more than 20, it was seen in almost 50% patients, that is 17 patients. So the patient screened were 50, out of that 36 were treated, screen failure, which will come into the subsequent slide. Out of that, 36 patient follow-up was ongoing in 14 patients, and 1 patient had a death during the follow-up. The treatment was discontinued in 29 patients. The reason were 9 adverse events, progressive disease was seen in almost half, 16, death was reported in 1 patient, and 2 patients withdrawn. And the ongoing treatment was given in 7 patients. So they analyzed out of 36 patients, 33 patients, and 3 patients which were excluded from the analysis due to grade 3 dysphagia. They received, 1 patient received alternative therapy, which was not evaluable. So screen failure reasons, again, as we had discussed in the inclusion, the exclusion criteria, because of the cavitary pulmonary lesion and patient who had inability to swallow the tablets. So these were some of the factors where the screen failure was there. Adverse event in all the patients, fatigue, diarrhea, and hypothyroidism was the most common adverse event. But when they combined more than grade 3 and above adverse events, dysphagia and hypertension with 8% each. But treatment-related adverse events, when we looked at the AST, GGT, and the hyponatremia were the most common one. Again, 8.3% among all the patients. Dose reductions, the reason for the dose reductions was oral mucositis in 23% patients, hand-foot skin reaction in 23%, and again diarrhea in 11% patients. And according to the physician discretion, the dose was reduced. So when the overall response rate was evaluable in these 33 patients, 50% patients had an overall response rate. There was no patient with a CR, or partial response was seen in almost 18 patients, 54. Stable disease in 12, which is 36%, and progressive disease was seen in 3. So overall, if you exclude this progression of the disease, stable disease, partial response, and this clinical benefit was seen in almost 30 patients, which is 91% patient of the cohort. HPV status, again, those who are HPV positive were a little better as compared to the HPV negative status. Progression-free survival, when they evaluated events were in these patients, median progression-free survival was 14.6 months, and 1 year progression-free survival was 54%, with a median follow-up of 10.6 months. Even in the OS, median overall survival was 22.3 months, with 1 year OS at around 68.4%. When the univariate analysis were done regarding to the OS, ECOG status was the only factor which was positive in the p-value. CPS score, though it was not significantly positive, but when you see more than 20 and less than 20 category, which was equally distributed in 17 patients each, if you see the median overall survival was 32.9 months, and 1 year survival, OS survival was 83.6%, which was significant on these values, but the p-values are not significant, but it's pretty high. And regarding the safety and the exposure, the observed AEs were, they were non-overlapping, and some dose reduction which was done to 20 milligram, they mitigated the observed toxicities. Dose reduction also did not appear to alter any clinical benefit, and there was no observed grade 5 treatment-related adverse events. So to summarize, this phase 2 trial of Pembrolizumab with Cabozantinib in recurrent metastatic settings in head and neck cancer, it met its endpoint, that was the improved overall response rate. The combination resulted in ORR of almost 54% and clinical benefit in 30 patients, that is almost 91% patients. 1 year progression-free survival was 54% and OS of 68%. That suggested that clinical activity, it exceeds more than rather than a single agent Pembrolizumab, especially in the group where the CPS score and PDL expression was more than 20, as compared to the Keynote 48 where it was only 30 and 56% respectively. Side effect profile did not appear to exceed the non-competing toxicities of both the Pembrolizumab and Cabozantinib. And it was a overall treatment was well tolerated, and treatment related toxicities also were reduced by dose reductions of Cabozantinib to 20 milligram rather than the 40 milligram. So this combination warrants actually further exploration in these patient group, that the recurrent metastatic setting. They have not given the blood biomarker data in the tissue analysis, which will be presented in the subsequent analysis. And thank you so much.